at Beach, who had rescued her. And
Hi, guys.
hi, everyone.
Hello.
How's
Hello.
it doing? What do you think? It's 2:30. We about ready to get started.
Sounds good. Rock and roll.
All right, sounds good. Amy, I think you were on mute, so if you were saying something.
Yep.
Okay.
Yeah, I think we can get started.
Okay, great. Well, thank you everyone for joining us for our quarterly meeting. I think at this point everyone knows me except for our guest today from On Point in New York City. I think since we've got Pia on the line here, we can probably go ahead and I'll give an introduction and go ahead and let her get started. So just by way of background,
Joan,
back in
just for
April.
1 second, can you just let people know that Matt McWeeny won't be able to join us?
Yes. So we did have 2 speakers on the schedule today. We were hoping to have Matt McWeeny from the Mosaic program at Cleveland Clinic. Unfortunately, he had a family emergency and will not be able to join us. So good news, bad news, we'll be missing out on that presentation, but it does sound like we'll probably be finishing up a little early today. I just wanted to give a little bit of background. Pia is going to be joining us from On Point, New York City Safe Injection Site. Back in April, here in Cleveland, we had Dr. Daniel Lettenberger Klein and I had an opportunity to talk on Sound of Ideas and started a discussion about safe injection sites and really some of the benefits and opportunities that those may offer for people who inject drugs and ways, sort of creative and innovative ways that hospital systems and our community can look at addressing the opioid crisis and the rising number of fatalities that we're seeing. Supervised injection sites are medically supervised facilities designed to provide a hygienic environment so that people can use illicit drugs and be able to do that in a safe environment so that we can prevent unnecessary fatal overdose. Goals of those injection sites also include reducing bloodborne pathogens and providing some connections to treatment. So I would like to go ahead and hand it over to Pia Marcus. Pia is the director of the Safe Injection Site On Point. And so with that, I think I'm going to go ahead and hand it over to you, Pia, and we're really excited to hear from you.
Great, thanks so much. I'm going to attempt to share my presentation. Did that work, guys?
Thumbs up.
Okay, great. Just maneuvering my screens here. Okay, so, sorry, just one more technical minute. Okay, we're in business. Okay, just loading. Okay, sorry for the delay, everybody. This should be loading now. Okay, thumbs up, everybody see the presentation? I can't see you guys and the presentation in this weird world that we live in. So
We can see it.
Perfect.
Yep, looks
Okay.
great.
Thanks, everybody. Sorry about the delay. I'm Pia Marcus. I'm the Director of Syringe Access and Program Innovation. I'm filling in for my Senior Director of Programs, Kaylin C. And I'm going to be talking all about safe consumption programs, also known as overdose prevention centers in New York. You might also see me throw my cat onto the ground every now and then, so bear with me on that front. Let's see if this slide was perfect. Okay, so 3 things that I'm going to be covering today. The first is really just to understand what safe consumption sites are, how do they function, how are they part of a larger ecosystem of care for people who use drugs, as well as the community. Second is to learn specifically about our models. We have 2 different safe consumption programs operating. One is a medical model and one is a peer or consumer-led model, which I'll go into great detail on. And then the third part of the presentation will really be about discussing how we managed to do this and what preparation and readiness looks like for another city or another state to open supervised consumption or an overdose prevention center. So why safe consumption sites and why now? This is a really important slide just to root us in our current landscape. Without a safe place to go, we know that people who use drugs are using on streets, in parks, in public bathrooms, behind closed doors. There's kind of this dual element of suffering both behind a closed and locked door or in the public eye. Neither of those conditions result in safety, result in support, and result in change. We really believe that people should not be using drugs in the street, in a park, in a playground, and or behind a locked door. We want people to be supported. As we all know, people who use drugs are everybody's child, mother, father, family member, whoever they may be, and care for this unique group of people is becoming more and more dire as we're seeing overdose rates skyrocket. We'll look at those numbers a bit, but I want to just point out on this picture we have my colleague Izzy, who's holding up the phone. Izzy started with us at 16 as an IV drug user. It's 10 years later, and he's now managing our naloxone program and our overdose intervention program. So really figuring out a way to bring active users into employment is a real thing that we believe in, and that also creates safety and stability and change in people's use. And the picture that Izzy's holding up is one of our participants who died in the tent behind him when our program was closed. So these are the conditions that we know are happening all over the country, and there is a way to stop this kind of suffering. I want to just point out that in 2021, the overdose fatality rate skyrocketed to 107,622. That is more deaths since World War II of all of our military inventions combined. That's a huge amount of death. Over the last 10 years, we're looking at about 1 million overdose deaths. Overdoses do not have to end in death. They should not end in death. And we're going to talk a lot about how we intervene to prevent this kind of catastrophe from happening, and we can make a difference. Up until recently, there's really been no compulsion to act because of who's dying and what they're dying from. We're starting to see a little bit of change in that area, and I'm going to talk about those changes as well. So there are over 120 safe consumption sites in operation all over the world. The first one opened in 1986 in Switzerland, and there's never been a fatal overdose in one of these sites ever, 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 ever. It's really important that I highlight that this intervention is not new. This is old news in other parts of the country. It's also the most peer-reviewed, studied public health intervention for people who actively use drugs, hands down. Nothing has been more studied in terms of an intervention from a public health perspective for people who use drugs than safe consumption sites. What we know is these sites cause decreases in community crime, they eliminate death, they decrease and eliminate transmission of diseases. But what I think we all kind of agree as Americans is, yeah, people can do whatever they want all over the world, but will it work here? And what would it look like here? Because America is unique. We now have an American example with American evidence, and that's what I'm going to be walking us through. So supervised consumption programs are infinitely scalable and adaptable. There are lots of different kinds of models that people can open and that exist all over the world. So a fixed site model would be one that is existing within a brick and mortar location. Medical models have medical staff who are working in the rooms and supervising the use. Peer and consumer-led models are staffed by people who are either actively using or former active users. The two models, one might think, would have different health outcomes. In fact, the outcomes are the same. The level of training is something I'm going to talk about a lot more, but we in New York City have both a medical model operating as well as a peer and a consumer-led model. These are programs that can be co-located within other programs. In Vancouver, Canada, they have a supervised consumption program located within a housing program and within a shelter. This is a really interesting and important idea, especially in the US, because we know that the majority of overdose fatalities are happening behind closed doors and in private and in people's homes. You can also co-locate a supervised consumption facility with a medical facility or a hospital. This exists in Paris, France, and in Vancouver. This is really about preventing some of the long-term and downstream health implications of people who use drugs not getting the care that they need. If you co-locate a supervised consumption facility within a medical facility or a hospital, you are ensuring that a person who is actively using drugs is able to stay in care. And when that person stays in care, their perception of themselves and their use and their relationship with healthcare changes. I'll talk more about that as well, but I just wanted to plant that seed. You can also co-locate with a detox or treatment center. Vancouver has done this. This is a really interesting model and an important model. This is really about dispelling the myth that abstinence-based programs and harm reduction programs can't coexist. In fact, we can and we do coexist, and we should coexist. There's also a pop-up or a crisis intervention model that I'll talk about kind of in a mobile setting. So this is a picture of a safer consumption program in Vancouver called Insight. This is to show you what co-location really looks like. So the first floor is where the safe consumption space is, the second floor is where detox services are, and the third floor is long-term treatment. What this means is when somebody is within a safe consumption space that has a detox upstairs and they say they're ready, they're going right upstairs. We're eliminating any need for a referral, for a pickup, etc. This happens all the time in supervised consumption facilities. It happens in ours all the time. When people are given care and seen in their use, which is something that people typically have to hide or want to hide because of the stigma associated with it, they start to look at themselves in a different way. What really struck me about opening our consumption programs is the amount of people that came in, sat down at a table and started crying. We spent a lot of time consoling people when we first opened and assuring them that their lives mattered and that we were there to help them. And we've seen tremendous changes in the ways that people use and tremendous changes in people's willingness to engage in an abstinence-based program. Again, I'm going to talk about that much more. This is what a mobile model looks like. We have an example in Montreal, and then we also have our model. This is really important to think about as we're thinking about how this could look in a rural setting across the country. There might not always be a building, a brick and mortar location where this kind of program can be set up. A mobile model really gives a lot of flexibility to bring services to communities wherever they are. In our model, we have a big RV, a Winnebago. What you're seeing on the right of the screen is the inside of our Winnebago. So there are 2 safe consumption opportunities. In the back is a doctor's office as well as a case manager office. The scene that you're seeing is after 2 heart attacks and 9 overdoses back to back. This was a really intense day for our team. What we realized very quickly upon having multiple overdoses was that the batch of heroin that people were using was cut with borax. We knew that because of the relationships that we've built with drug dealers in Washington Heights, and alerting them to what we were seeing and the severity of what we were seeing. Because of those relationships, we were able to pull that bag off of the market and stop the overdoses that were occurring based on that bag. What's really important about this example is that nobody died. This was a really, really serious, really, really high level of care that was needed for 9 different people, again, and with 2 heart attacks happening at the same time. And what surprised us was EMS arrived to transfer care multiple times. And eventually they said to us, don't call us to come unless you're ready to transfer care, because you guys have this covered. You don't need us. You just need us to bring somebody to the hospital if they need to go to the hospital. So you make that call. We are responding to too many calls in the community, and they're going to die in the community if we don't go there first. And we said, no problem, we got you. That has tremendous implications for what downstream costs to the healthcare system look like, and what kind of care people need, even in the most dire of circumstances. Finally, there's also a virtual model. Both of these operate internationally as well as in the US. This is a program where you can call one of these, you can call this phone number, or you can use an app that you as the drug user are giving personal information to. You're telling this hotline or this app where you live or where you're sleeping, what you're using and when you're using it, so that somebody is there to make sure that you're responding. In the phone call version, that looks like somebody on the other end of the line saying, hey, are you okay? And if they don't get a response, it's triggering a 911 call and using the information that the person has given to that program to find the person and intervene in their overdose. In the app-based version, there's a countdown. You see 20 is on the little picture of an iPhone. That counts down, and if the person's okay, they can click that button and say they're okay. If they don't click the button, again, that's going to trigger an EMS response. So what's really interesting here is this is a safety plan that's tailored to the individual. It's giving somebody care on their own terms, right? They're in control of what information they're giving, what information they're not giving. And it can even include details like my spare key is under the planter outside the front door to my building. These are all important interventions that can and should save lives. Okay, so how do our own sites work? I'll be showing you lots of different pictures and talking about this in depth, but to get us started, our consumption programs are polymodality and polysubstance. What that means is people can shoot, smoke, sniff, or consume in any way their drugs. This is unique. Not many supervised consumption programs around the world allow for polymodality. There are sometimes strict rules around what modality you can use when. This was really essential to us meeting the needs of our specific population of drug users, which again, I'll talk in more detail about. We do not provide drugs. We provide supplies. People have to bring their own drugs into the program. People are asked what they're using and how they're using it every time they walk in. We allow splitting. Splitting is when, let's say, I arrive at a consumption program with my best friend. My best friend has cocaine and I have heroin, and we're going to split the doses between us so that we can both use our desired drugs of choice. Splitting is not typically permitted in places around the world. We permit it because we work with an extremely impoverished community. We know that people are not going to be able to necessarily get their hands on the drugs that are going to make them not feel sick anymore, but that a friend might be able to, and that people help each other to make sure that they're safe and they're okay. Splitting happens under very, very strict observation. If people have more questions about splitting, I'm happy to talk all about it. We are also unique in the kind of safe use assistance that we give. There are some programs that people can walk into, they can go to their booth, they can sit there, but staff cannot help them. We believe that if people are going to have an opportunity to exit their use, they should not have to exit their use scarred and harmed by their use. Yes? Did I get a question? Okay. So yes, we believe that people should people do not have the opportunity to exit their use if they're covered in scars, right? And what we saw very clearly when we first opened is even though syringe service programs have existed in New York City since the early 90s, people really don't know how to inject drugs properly, and it's causing a lot of harm and a lot of damage to their veins and damage to their bodies. So helping people understand how to use safely and effectively is a really key piece of education and assistance that we provide, because it's giving autonomy and power back to people. Really, what these programs are about is bodily autonomy. You can do what you want with your body. We often see, especially with female and male relationships, that there can be a reliance of the female on the male to inject rather than self-injecting. That kind of reliance and that kind of dynamic can be very toxic, and it gives no power to the person who doesn't know how to do for themselves what they need in order to not be sick. Again, we're talking about people who are chemically dependent. So being in withdrawal is something that people are constantly faced with. We also don't have time limits. The way that we work the site is really about managing flow. We want to make sure that people are coming in and not rushing. We also are making sure that people aren't camping out at the site or at the booth and not allowing another person to come in. So that is delicately and very strictly managed by the staff in the room. We're also unique in that our staff are very highly trained. All of our staff entry level up are trained to respond to an overdose at the level of a nurse. That means we're inserting oral airways, nasal airways, we're using ambu bags, we're using oxygen tanks, we're administering naloxone intramuscularly and tapering those doses. This is not just simply a Narcan training where you learn how to spray Narcan up the nose. In fact, it's a much, much higher level of skill that's required to work in our sites. This is a very low threshold program. You can anonymously enroll, give a fake name. You have to, in order to enroll, you have to work with the staff and tell them a little bit of history of your use, where you're using, where you're buying drugs. We want to know what neighborhood you're hanging out in. We want to know how often you use, how long have you been using, kind of like who are you? And then sign a code of conduct. The code of conduct includes a release form as well as our rules and expectations of people when using within our site, how to relate to staff, things like that. We're also unique in that we use a model of de-escalation that includes what's called an opportunity to correct. So if someone is acting out or crossing a boundary of the program, a clear directive is given them about what they have to do to correct their behavior. naming the behavior and then giving instruction to correct is an opportunity to correct. If somebody doesn't take that opportunity and continues to act out, continues to not follow the rules and instruction of staff, we ask them to leave for 24 hours. 24-hour clock is like a reset button. It gives the participant a chance to reflect on what happened in the program, what it was that they stepped out of bounds with, and an opportunity to come back. Because what we know is people who use drugs are most often not able to access services in most traditional places. It might be because they have gone there before and their behavior, being high, nodding out, whatever it might be, was unacceptable. So there's really no place for people to go. As the place where people go when they can't go anywhere else, utilizing a model where we kick people out is not going to actually solve the problem. We do have to work through very challenging behavioral issues, and we do escalate beyond a 24-hour suspension depending on what happens. But most often, we're giving people an opportunity to correct, and we're giving people 24 hours before they can return. And that's worked really, really well for us in de-escalating conflict and asserting firm boundaries. All supplies that are used in the overdose prevention center stay in the overdose prevention center. This has a huge impact on syringe litter. We'll look at the haz waste that this program accumulates, but it's just really important that I emphasize that there is no more distribution of supplies when you have a consumption program. You give the supplies in the room, and those supplies are then disposed of in the room. Again, that's how we're eliminating disease transmission. There is no opportunity to reuse a syringe when you have a new syringe every time given to you and your old ones are taken and disposed of. Finally, we provide very high levels of clinical care and mental health care at the booth. We have social workers that go into the consumption program to meet with people. Same thing with clinicians, doctors, nurses, physician assistants. This is true in both of our settings, and they are both co-located within larger programs. That's a really important piece of information that, again, I will talk in more depth on. But we believe it's very important for supervised consumption facilities to not just exist on their own. They need to be linked to other care, because you have a responsibility to provide people the care that they're asking for, and you have a responsibility to the community to make sure that people aren't being discharged from your consumption room too quickly. Opponents say a lot of things about supervised consumption facilities. Almost everything that people who are against this intervention say has been proved wrong by the decades of peer-reviewed studies. There is one criticism though that does have legs, we believe. There are people who say that discharge from the consumption program happens too quickly, and that people end up on the street high or even overdosing very latent, and that death is then brought to the community rather than happening within the program and intervening. This is true, we believe, in terms of people being discharged too quickly and having people kind of congregate on the street who might be intoxicated or at risk of overdose. The way that we avoid that entirely is by situating the program within a larger program. So our overdose prevention centers exist in buildings that have a drop-in center. The drop-in center is basically like a living room where people can hang out, have coffee, we have hot meals, and also be connected to our other services. The other services we have are case management, we have mental health counselors, we have clinical care, we have holistic care, acupuncture, etc. All of these things work together to keep people safe and give people opportunities to change their use. So really, really co-location is really an important part of this success. Okay. So our Washington Heights location is our peer or consumer-led model. Again, this means that the people who are staffing this program are either actively using or recently in recovery. This is a very, very cost-effective intervention. As you can see in this picture, and you'll see more pictures, this is just a mirror and a table. That's all you need. We really want to show that building these kinds of programs doesn't have to be expensive. It can if you want it to be, but it doesn't have to be. In Washington Heights, we serve a much younger population. We have a very high volume of what's called speedball injections, which is heroin and cocaine. Speedball injections, especially with younger folks, and I'm talking early 20s, is a very risky mode and choice of drug use and the reason for that is multifactorial. So the first piece is if you're injecting heroin and cocaine together, you're doing multiple injections in one sitting. As you see in this picture, there are multiple syringes on the person's table. They're using multiple syringes to get just one of their doses. The half-life of heroin is about 5 hours. The half-life of fentanyl is 2 to 3. So as we see the heroin market really being concentrated by fentanyl, and what we're seeing is there is no heroin in the market anymore. For poor folks who are using our programs, you can't get your hands on it. It's all synthetics, and it's mostly fentanyl and filler. So if you have a situation where you're using a drug that has a short half-life, you're going to go into withdrawal quicker. Cocaine also has a very short half-life. It's 45 minutes to an hour. So you might be injecting multiple times in one sitting, and you might be injecting 10 to 12 times a day. That means there are 10 to 12 different opportunities where a person can overdose and die. This is all happening on site in our program, where we can really intervene and prevent death, but also ensure that this really, really vulnerable population is connected to care. Again, this isn't just a room where people can use drugs. It's a room surrounded by a whole bunch of other services that hold people in different ways and connect them to care in different ways. Just to hammer home the vulnerability of this population, this is a very, very high population of street homeless individuals. They're extremely service resistant. This is really the entryway for these folks into other kinds of care. They're not interested until they come into the room and they get the care that they get in the room. And we're also able, again, to send providers into the room to meet with them booth side. We have a higher overdose occurrence rate in Washington Heights as opposed to East Harlem. That rate is driven by these factors: younger population, high risk drug use, as well as very chaotic circumstances in life. We have fewer registered users in Washington Heights, interestingly, although the overdose rate is higher, and we'll get into that a little more too. These are some more pictures of the Washington Heights location. Again, what you're looking at is supposed to look pretty bare bones. Tables, chairs, mirrors, lights, that's it. You really only need a table and a chair in order to do this. The mirrors provide many different safety mechanisms. So for the user sitting in a chair with a mirror, they can see behind them. That's a luxury. People who are using on the street are often having to hide and having to look behind their back to see who's coming. Being able to see your surroundings enables the person to calm down and to have more trust in the surroundings. It's also a safety mechanism for staff. I can check on a person by standing behind them and not looking them straight in the face, because I can see their face in the mirror. So if we're starting to see any kind of eyelid drooping, any kind of indication of initiation into overdose, we're intervening. What you're looking at also in the top left corner is our crash carts. We are giving intramuscular naloxone that you see prep there. You're looking at oral airways, nasal airways, scissors in order to take off somebody's clothes to use an AED, as well as oxygen tanks. And I can answer more questions about all of this in the Q&A. Okay, let's hope that this video loads. Yeah, okay, so this is a short video about our Washington Heights location.
My name is Clara Cardell, and I work in one of the first 2 public overdose prevention centers in America. Come on in. One of the first things we do when a participant comes in, we ask them some questions like what they're using and how. We like to know if they weren't using here, where would they be using? We ask them to pick a booth, or we assign them a booth or a smoking room if they're going to smoke. We have all the supplies we need here. We're always watching the mirrors. The mirrors tell us a lot about how people are feeling.
Everybody move back, please. Vito in the house. Vote for Vito.
I've come in and seen somebody in 20 seconds, his head go down and stop breathing. So this is our crash cart. We have pulse oximeters, oxygen, and we have Narcan and our tip backs that will not make the person go in withdrawal. We are human beings. We have the right to have a place we can use safely and don't have to worry about someone finding us dead in the morning of an overdose. As someone that uses this site and also works here, I understand what our participants go through. This work means so much to me. I have started to use less because I rather work and I just forget about using a little, because this is so important to me.
It's been approved by Vito.
Okay. Transitioning into our Harlem location. So in East Harlem, this is where we are using a medical model. So this is a design and build and higher cost. You'll see traditional booths that are often in Europe and give a little bit more privacy to people than the open concept that you saw in the previous location. This is really important because we built these 2 different models to meet the needs of the community. So in Washington Heights, we have people who want to use together. Remember, this is a young population. It's a very social dynamic up there. They want to talk to each other. They want to be in community while using. In East Harlem, the community is very, very different. This is a much older population. A lot of folks are stabilized on methadone and either using on top of their methadone or inhaling drugs. We have a lot of veterans. And we have a lot of folks that have come straight from Puerto Rico who are also much older. So when we opened in East Harlem, the first reaction we got from participants was like, are you crazy? We're not going to do this in front of people. That's really disrespectful. And so we had to build trust and get people comfortable in the booths. For a while, we put up privacy screens to make people feel like they had more privacy while we were still able to come in and supervise. Now, almost 6 months later, we don't have privacy screen use at all. People don't ask for it anymore. They're comfortable with the level of exposure they have because they know that exposure is a safety mechanism as well as a connection for them that they want and feel. There are medical licensing considerations when staffing a site like this. We don't have federal, state, or city approval in writing. I'll get more into details on that. But that is something to consider in opening a site like this. We have a very high volume of inhalation in this program. Heroin, quack, K2, meth, cocaine, all being smoked on site. Again, we designed the site with additional inhalation rooms in order to meet the needs of the community. This is also a pretty mixed community in terms of housing. Some people are housed, some people are in shelters, and some people are street homeless. There's a lower overdose rate in our East Harlem location as opposed to our Washington Heights location. That's all about route of administration and the drugs that people are choosing to use. Crack smoking is just inherently less risky than injecting an opiate. We also have a higher number of registered users in East Harlem, so we see more people and have more visits in East Harlem than we do in Washington Heights. We have a very small and very dense population in Washington Heights. This is looking into the booths. Same model in terms of supplies. First thing people do when they come in after they're telling us what they're using and how they're using it is washing their hands. Washing your hands is not only a sanitation prevention, it's also an opportunity to massage where you might be injecting with hot water to raise the veins. We also give hot towels at both locations, again, as a mechanism to raise veins and improve access. Supplies are taken by participants, whatever they want is there, and the overdose intervention is exactly the same. This is our communal smoking lounge. This accommodates 4 to 5 people at a time. We also have an individual smoking room for participants who want privacy. This is an airlocked entry system. As you can see, there's 2 doors leading into this, and they're both fully sealed. So both doors can't be open at the same time in order to keep the smoke in and vent it out. There's special ventilation in this room. It's basically like an industrial air fryer to vent out the smoke. We also have an intercom in there so we can check on people, and staff go in to talk to folks and clean as well. And this is a short video of Harlem.
Hey, I'm Race, and welcome to the East Harlem Overdose Prevention Center. Addiction and drug use is really personal to me and my family and my friends. I've lost a lot of loved ones to overdose, and it's an honor to be working here, running one of the first overdose prevention centers in the US. Providing love to our participants and seeing the empowerment has really changed my life for sure. So here are clean, safe supplies. We've got everything for our sniffers, our injectors, and our smokers. So everything that's used in here stays in here. They're not being littered out into the community. It all stays in this room. This is one of our booths. The mirrors are really important. I can look at people's reflection in the mirror without invading everybody's personal space too much, and I can safely make sure everybody's okay. This is our vein finder. It allows us to help participants find a vein and different unique places they can use that'll let them be safer and reduce track marks. We're empowering our participants who are already using to be the healthiest and safest drug users that they can be. These are our smoking rooms, a space for people to smoke their drugs. There's a high-powered HVAC system in there and a dual airlock door. So no smoke is coming out of that room. It's all staying in there. Everything I use in an overdose response is right in this cart. So we've got oral airways here, our nasal airways, very important in the age of fentanyl that makes you clench up. This is a pulse oximeter. It's measuring oxygen saturation and heartbeat. This is one of our oxygen tanks. We have it set up with a pony mask and then a full ambu bag when we're breathing for somebody else on their own. Another big tool we use in our overdoses are our intramuscular Narcan shots. This is 1/10 of the dose of a nasal Narcan shot. So we're bringing people up out of overdose very slowly, but not bringing them into withdrawal. This is Brian, one of our other managers here. So one of the big differences between our site here in Harlem and our Washington Heights site is that we are the medical model. So Brian has experience as an EMT and working in the medical field. And so we have that extra expertise to come help us along.
My mom was a heroin addict, so I've experienced that in-house, and I didn't know what to do at the time. That was the reason why I became an EMT. And when I was EMT, I just felt like I wasn't doing enough. So here is just, I don't know, I save lives every day.
Okay, we're gonna look at some of the data. And I am cognizant of time, so I'm gonna start speeding up. So since November 30th, when we launched,
I just want to say we don't have our second speaker, so please feel free to take as much time as you would like.
Okay.
We would like to make sure we have time for questions at the end.
Yeah.
But I think you're doing great with time.
Okay, time. Be like, nobody's falling asleep on me.
I think we have more engagement for this talk than we probably had in any of the talks that we've had. This is wonderful.
Okay, wonderful, great. I will then slow down and get to everything. And there will be time for questions. Okay, so since November 30th, 2021, when we launched, we have different amounts of registered users as well as utilization. So the registered user is one individual that has enrolled in the program. Utilizations could be one person coming back multiple times in one day. We have 1,500 total registered users. As you can see, like I indicated earlier, we have a significantly more registered users in East Harlem than we do in Washington Heights. But we're going to talk about what that looks like in terms of overdose. Utilization, we're also seeing more utilization in East Harlem. That's really, again, driven by inhalation. People are coming in and smoking and leaving and coming back to smoke and leaving, coming back and smoking. Smoking doesn't take as much time, right? So you don't have to take the time to prepare. You don't have to take the time to find a vein. All of that increases the amount of utilizations we can have. Washington Heights, though, still seeing high levels of utilization. This is looking at our overdose intervention. Talk a little bit about the data and also explain what you're looking at. So first, we've intervened in 399 overdoses so far and counting. East Harlem, we've intervened in 147, and in Washington Heights, we've intervened in 252. So again, even though we have a much bigger population in East Harlem, the population in Washington Heights is smaller but higher risk. And we're seeing that play out in the consequences of their use. High incidences of overdose, many opportunities where people could have died and they did not. We break overdoses up into 3 different categories. They are all overdoses. We have 2 different categories for opioid or depressant involved overdoses. We've intervened in 306 since opening. In 78, we've had to use naloxone, and in 228, we have not had to use naloxone. I want to stress that just because we didn't use naloxone does not mean that that overdose would not have progressed to the point of death. It absolutely would have. What's interesting is because we are able to intervene the moment a person starts to dip into an overdose or their respiration starts to slow down, we're right there. So the majority of opioid or depressant involved overdoses that we're intervening in require agitation and oxygen alone. That's it. There's no need for naloxone. If we can prevent a loss of consciousness, we're going to keep the respiratory system firing. We're going to keep the heart firing. We're going to keep the brain firing. That happens in a few different ways. That could be continuous sternum grinding with an oxygen mask. It could be trap squeezes, really whatever is going to take to keep that person up. We're with them side by side. In those situations, we don't have to bring somebody down to the ground. What you're looking at in this picture is somebody who completely lost consciousness. When there is a loss of consciousness, that's when we're starting to use our injectable naloxone, as well as using an ambu bag to breathe for the person. What you can't see underneath that ambu bag is there's either an oral airway or a nasal airway inserted into that person. There's a pulse oximeter on their finger. We're monitoring what their oxygenation is, and we're with them kind of every step of the way as we ease them out of this. Easing somebody out of an opioid or depressant involved overdose means removing as many opiates from their receptors in order to breathe, but to not cause withdrawal. So they talked about, or my team talked about this a little bit in the videos. The intramuscular naloxone that we're using is a micro dose compared to the 4 milligram nasal that's often given out. 4 milligram nasal in certain circumstances is incredibly important. However, when we can intervene at the immediate onset, we don't need that high level of dose. Not needing that high level of dose also means that we can titrate only to the point, again, that someone is able to breathe on their own without throwing them into precipitated withdrawal, which is what naloxone does. If you bump too many opiates off of the receptor, you cause the person to feel as if they're in withdrawal. Overamps is the third category of overdoses that we intervene in. Overamps are stimulant-involved overdoses. These can sometimes involve cardiac care necessary. We haven't seen that yet. We are prepared to intervene in a cardiac emergency. I told you about the 2 heart attacks that we had on the mobile unit. But really, stimulant overdoses are all about calming the person down and cooling them down. They're often sweating a lot, paranoia, psychosis, hallucinations, the works. Being surrounded by people who know them, who know their triggers, who know what's going on for them in those moments is really crucial to being able to calm the person down. We have called for EMS 5 times out of 399 overdoses. That's a really, really remarkable number. And that's being driven by a few different things. The immediacy of the response, again, we're there at the moment that a person respiratory system starts to decline, or the moment they start to be exhibiting signs of an overamp. The high level of training that our staff get and their level of skill is really important in not driving an ambulance call higher. Again, all of our staff, entry level up, whether you're an active user or not, are trained to the level of a nurse in overdose response. So the staff that you're seeing in this picture, none of them are clinicians, but they do have the skills to avoid an EMS transfer. We're really treating symptoms in our overdose response, and the different symptoms of overdose are treated in different ways. Yeah. Times in which we would call an ambulance, unresolved seizure activity, or any kind of cardiac involvement. If we are having to do compressions or use an AED, we're calling EMS. But again, you're seeing how infrequently that happens. Okay. Since we launched, we have accumulated over 600,000 units of hazardous waste. This is what's been diverted from parks and public spaces. So if you think about every single utilization of the site, that is a use of drugs that would otherwise happen in the street, in the public, or alone and behind a closed door. This puts a tremendous burden on the community, right? So having a supervised consumption program is really a community intervention. In our instances, we had community members begging and pleading for drug users to not be in parks, not be in public spaces. And we agree, they shouldn't be there. It's not okay for children to walk by somebody injecting drugs. This is a very intense, personal, and private thing that somebody does that should be observed only by trained staff. Knocking my cat off. In a park right next to our Washington Heights location called Highbridge Park, prior to us opening our supervised consumption facility, was really like an open air consumption location. We were servicing these areas, providing overdose response on site, cleaning up syringes, constant maintenance. We have a very long relationship with the Parks Department. When we opened November 30th, about a month later, the Parks Department called us and they said, "What the hell is going on? We've seen syringe litter drop from 30,000 needles in 1 month to 1,000 needles. Did everybody die?" And we said, no, that's what a consumption program does. That's what we've told you year after year after year is what we need to get people out of your parks. So this really, really works. And it's amazing to see the difference in our public spaces and know that these spaces are really being utilized correctly now. Just to tie this all up, what we know, not just from New York City and our intervention, what we know from the decades of peer-reviewed data and surveillance of supervised consumption programs, they eliminate or reduce discarded syringes in public spaces. They eliminate the spread of hepatitis C and HIV. They minimize police interactions and the cost of the criminal justice system. What was really interesting in New York City is we've had not the most positive relationship with the NYPD over the years. I've been with the organization for almost 7 years now, and we've been through a lot with the NYPD. In New York, we know that stop and frisk still happens, even though the police says it doesn't. However, NYPD coming on to support this program was really important in us determining readiness to open. that I have more about, but I just want to say that the NYPD does not want to be dealing with drug use. They have seen over the decades of the war on drugs that what they're doing is not working, and having somebody else to give people to and to transfer care to has been a real relief from them, for them. They asked us to create informational flyers with our logo on them so that when they approach a person who might be actively using or might need substance use care, they can give them a flyer with our logo so that there's a little bit more trust built rather than an officer approaching them just as an officer. And the NYPD is also dropping people off at our door. They're picking people up in public spaces and saying, come on, I'm going to give you a ride over to the site. Consumption spaces eliminate overdose death. They reduce public disorder and public drug use, and they radically decrease costs for healthcare systems. Even now, we're 8 months in. I think I said 6 earlier. We are in fact 8 months in. We're still enrolling existing participants. So one thing that people think happens when you open a safe consumption space is that everybody flocks to it and it becomes kind of like a honeypot. That's not in fact true. People from all over New York City are not traveling to use in these consumption rooms. We are enrolling existing people who we have existing relationships with, or people in the surrounding neighborhood who we haven't been able to give care to because they're so service resistant. We're really enrolling more of the service resistant folks that we've attempted to engage in care for a very long time than necessarily enrolling people who are coming from far away. We also really put our money where our mouth is. We hire active substance users. We have a maintenance use policy. So people who are actively using need to use only during scheduled breaks, and they have to only use enough to not be sick, but not enough to be too high to intervene in the complex overdose. That's a really important boundary that we have with people and that we uphold in a lot of different ways in terms of how we work with our active users who are employed. But as you heard Clara say in the Washington Heights video, having a job is an incredible stabilizing factor in changing somebody's use. So while Clara is not interested in stopping entirely right now, having this job has reduced her use. We also know that supervised consumption spaces do just that. The stability of the program and the care that comes with them increases access to medical care, increases access to detox and treatment, and stabilizes people's use. We have a man who allows us to share his story named Jay. In the park that I was telling you about with 30,000 discarded syringes prior to our opening, we have a spot called Jay's Spot where Jay has overdosed probably more than a dozen times, and we know to go find Jay in that location. Jay now uses in the site. He's one of our older participants in Washington Heights. He's in his 50s. So he's been around for a long time. He's been using for decades. He now sniffs instead of injects. So we've managed to help him change his route of administration to decrease his own risk, which is leading him to decrease his own use. That's a very different trajectory than going in and out of drug treatment. And I do want to say that every single person in our program who's using on site has been to detox and treatment more than 5 times. That is a cycle that we should expect. We should expect people to enter detox and treatment and then return to use. That's okay. That's the reality. We like to say that abstinence fails every single time until the one time it doesn't. There's only one time, and you need a way to catch people who are actively using, so they're not just sentenced to death. So more on participant impact. You can see here in the pictures that these are the programs that are happening around and outside of the consumption room. So you have our holistic space in the top right corner where we have acupuncture, massage, Reiki, Tai Chi, the list goes on. Bottom right is our clinic. We do hepatitis C treatment on site. We provide Suboxone or buprenorphine on site. So we are in fact a treatment provider. We do lots of wound care, HIV stabilization, and we're working towards being able to provide primary care. And then on the bottom left, you're seeing a case management session. This is counseling, this is housing navigation, this is benefits navigation, this is connection to psychiatric care, all sorts of things. 80% of OPC participants were connected to other services directly from the OPC. So within the room, they're being connected to detox, medication as treatment, medical and mental health care, or HIV and hepatitis C care. We saw very high rates of overdose rates in the first few months that we were operating, and those began to plateau and decrease around the 7-month mark. So what's happening is exactly what we know happens with supervised consumption programs. Again, this has been studied for decades. Researched, peer-reviewed journals about, peer-reviewed articles about this, this way in which consumption programs stabilize and decrease people's use. And I've talked about hiring active substance users. Okay, so how did we do this? This was a very unique political window that we had when we opened. The first was Mayor de Blasio was on his way out. He did not have much of a legacy to leave behind, and he decided that he wanted to throw his weight behind supervised consumption as a way to build his legacy. Did we know that he was doing this for his own political game? Perceived. Absolutely. Did we care? Absolutely not. We leveraged whatever we could to get these sites open because we knew they would save lives. We also had a really interesting transition at the governor level. I'm sure you know that Governor Cuomo was dealing with his own scandals, and Kathy Hochul came in after Cuomo went out. We did risk analyses at the local, state, and federal level. What we did was giving policies and procedures to the Department of Justice, to ONDCP, not giving them too high up in the ladder, but just high enough that we knew they would be, that these documents would either be sent up or communicated up, and we waited to see what happened, and nothing happened. We really had very, very amazing partners in City Hall and our city health department, as well as our state health department. They let us take the lead. They knew we were the experts in this. They knew that we knew what we were doing. Our senior director of programs has run supervised consumption facilities in different models in Canada for many, many years. Having her was an incredible piece of this, to have the wisdom and the expertise necessary to run this and to train staff to do it. We also had staff already trained, and I'll get into that piece. Not all health departments will allow a nonprofit to take the lead in this way, so that was very unique in New York City. We looked at the case in Philly where they attempted to open a supervised consumption facility, and under Trump, the Department of Justice said no. We also looked into a few other things that were going on in the country, and not far along in our process, again, we did not receive any interference. So this led us to believe that we would open. Our community engagement strategy is really tied to our ability to open. So there was both a long-term strategy and a short-term strategy. The long-term strategy was, we have been operating semi-unsanctioned supervised consumption for the past 6 years before we opened. What I mean by that is we were running a program out of our bathrooms for consumption, not supervised, but monitored consumption. The New York State Health Department has a a policy and procedure and requires syringe service providers, us, to have a policy and procedure in place in the case of an overdose in a bathroom. The way that that is written and the directions that are given to syringe service providers is you need to have a policy and procedure on your books, because we know that if you give somebody a syringe in a program with a bathroom, they're probably going to go into the bathroom and use that syringe. And we as the health department don't want anyone to die in your program bathroom. So you guys need a way to deal with that. The way to deal with that was left up to the programs. Some programs decided to just write a policy and procedure and put it on a shelf. We decided to build an infrastructure around our bathrooms. So in fact, we installed steel tables, mirrors, and a chair in each of the bathrooms. We had 15-minute time limits. Every 5 minutes, we knocked on the door and checked on the person. If the person didn't respond, we went in. This is a community engagement strategy because we very carefully over the last 6 years decided how and when we were going to let people in on this. So it was really important for us to decide when the moment to tell the NYPD was that we were doing this, when the moment to bring in state senators and show them the way that we were working, really as a way to show that we are part of the solution. We're not part of the problem. We think we have something brewing here that could really work if it was expanded, and get community buy-in for this kind of intervention. We really advertise this as public injection diversion, which people, again, really, really wanted in the community. In the short term, our community engagement strategy looked very different. So we have this long-term 6-year strategy of an unsanctioned program and bringing people into a little bit of a secret, let's say, of how that's working and why that's working in that way. In the lead up to opening these sites, so building them, closing our bathrooms, because the consumption programs are now situated where the bathroom programs used to be, was not communicated. It was really important to us, and we knew that we had to open and bring the community in when we opened to see what we were doing, rather than bringing them in before opening. They had already been let in to the fact that this was happening on a smaller scale, and giving people fodder to turn against something that they don't really understand, we didn't think was wise. You can't understand this intervention unless you see it, because it doesn't exist in the US, right? So it's even very challenging for participants to understand what the program is without seeing it themselves. So when we enroll a new participant, we bring them into the OPC and show them, to explain to them what this program is and why they shouldn't be using in other places. We found that at a community level and at a participant level, it's just the same. If you can't visualize it, if you can't see it happening, if you can't see the immediate effects of what's going on in the program, there are lots of different ways that you can misunderstand it or turn against it. And we didn't give the community that opportunity. Once we opened, it was full transparency, tours anytime people wanted, and really building on our existing community support.
Pia?
Yes.
I hate to interrupt.
No.
We are getting a little close on time, and I know people have questions.
Yeah.
Do you want to finish up any additional remarks, and then maybe we can open it? I see Jean has put a question in the chat.
Yep. I can finish this slide and then we can move straight to questions.
Wonderful. Sounds good.
Okay, so finally, our NIDA evaluation. Rhode Island already had federal approval to evaluate supervised consumption facilities, and they invited us into their study. That was a really key piece of us being able to open as well, because it gave us federal permission to operate these sites as research studies. So we're working closely with NYU and the Department of Health in New York City to evaluate these two different models, the medical model versus the peer-based model. But again, like I've said over and over again, we have so much peer-reviewed data about supervised consumption. We know that the two different models have the same outcomes in terms of care, diversion from public use, et cetera, et cetera. we did that very strategically, not only to meet the needs of the communities that we serve, but also to give blueprints for the rest of the country on what different models people have the opportunity to lead. So with that, I just want to plug that we are available for technical assistance. We can train communities, we can train nonprofit organizations, we can train hospitals, et cetera, on how we're doing this. And we're really eager to do that to help. And yeah, we can launch into Q&A now.
Awesome. Thank you so much, Pia. I cannot, thank you enough for the work that you are doing. You are just an incredible ambassador for the people who use drugs in your community. They are so lucky to have you. And I was hanging on to just about every word that you were saying, that everything is just, new to me as far as these programs. You are lucky to have a pretty educated audience here. The folks here on this call are all physicians, hospital leaders, and at least 3 of our hospital systems either have operational syringe exchange programs or are in the process of developing one. We have, well, why don't we start off with one of the questions from Dr. LeCamp at University Hospital. She asked in the chat, what is the reaction or behavior of the drug dealers in the neighborhoods near your sites? I know you mentioned that you have a long-standing relationship with some of them. How have they interacted with your programs? And I would add, do you struggle with dealers trying to sell or solicit your clients?
Yeah, great question. I love talking about our dealers. So first part of the question, how have the dealers reacted to this? The dealers are relieved. The dealers are happy that there's a place where people can go that isn't the street. A lot of what happens around drug sales is a policing of the blocks by drug dealers to make sure that people aren't using on the block. They don't want that kind of heat coming on them. So kind of exactly the same as NYPD's reaction, which is like, take this issue off of our plates. Like, that was the drug dealer's reaction. The other thing that has been great is to bring dealers in closer to drug testing. We were already doing that a bit, but we're starting to expand that more now that our relationships have had time to grow. And people want to know what they're selling. The people the dealers that we're working with are not so high on the totem pole, but they're not super, super low either. And they don't know what they're getting. They're just cutting it into doses. Sure. So them knowing what's in their drugs is an important part of their business as well. Do we have problems with solicitation? We really don't. We've had one particular, it's not really a group. We've had 1 or 2 dealers that have worked on our block in East Harlem far longer than we have been in that program. Bringing them into the fold and really working with them around what is and isn't okay to happen outside of our site and how to share the sidewalk and the public space has been really important. And that work only happens with the bedrock of relationships.
Awesome. I think it looks like Dr. Stream, who is one of our addiction specialists at the Cleveland Clinic, has his hand raised. So I'm going to open the floor to Dr. Stream.
Thanks, Joan. Thank you so much for your presentation. You mentioned and discussed in a little bit of detail the Vancouver operation. Yep. And I just came back from a few days in Vancouver. I didn't get to see the centers that you mentioned, but I did get to walk down Hastings Street, which was an experience. So I wondered, I guess my question was, have you had an opportunity to see firsthand any of the Vancouver sites, and what sort of volume would you say they're seeing? Are those sites as about the size that you displayed in some of your pictures, where you'd have 5 or 6 using booths? or are they larger?
I have not personally been to Vancouver to visit the sites, but I do know a good amount about them. The slide that I showed, like the first initial slide that I showed, was a picture of Insight in Vancouver. They have about 15 booths, and we have 4. Sorry, we have 8. So it's a much higher volume in Vancouver. The program that my supervisor, Kaylin C., ran, which was not Insight, but had a consumption room attached, served 1,000 people a day. We're not seeing 1,000 people a day. That's significantly higher than us. But the criticism that I talked about in terms of discharging too quickly is a criticism that we have of Vancouver, including Kaylin, who has worked in Vancouver. A lot of what is being seen on the street in Vancouver, we believe could be avoided if the consumption programs were better embedded into other services. So it's great that Insight has a detox and treatment center above, like that's the dream, but also it should have activities for people to do. It should have places for people to hang out. It should have a food program. Like, we're really building one-stop shops to get people off of the street entirely.
Interesting, thanks.
Mm-hmm.
Looks like Tom Olmsted has some questions, and I think you may have answered this. How has the NYD responded to the OnPoint program?
Yeah.
Yeah.
I can just say again, they love it. They're big fans. We brought them into our unsanctioned program over the last 6 years. And so we had buy-in at very high levels in NYPD. It was really the beat cops that we were worried about the most and that were having the most kind of issues prior to opening our sanctioned consumption rooms with our participants. But now that they have a place where they can send people and they have an opportunity to push something off of their plate, they're really on board. And we have NYPD officers who would love to talk to people in other cities.
And it looks like Anne has a question. How did you choose the 2 neighborhoods for your locations where you're first starting out?
Yeah, great question. So we didn't choose them. We have been working in those neighborhoods for far longer than I've been working for these organizations. So our East Harlem location has been working in East Harlem for almost 30 years. Our East Harlem location was an organization that grew right out of the ACT UP movement and was operating a legal syringe exchange prior to the legalization and sanctioning by the New York State government. In Washington Heights, we've been operating there for, I think, 16 years. It started as a nurse working out of the trunk of her car.
Wow. Pia, what are the hours of operation?
Yeah, the hours of operation are currently 9 a.m. to 8 p.m. in Washington Heights, and we recently expanded our hours in East Harlem to 6 a.m. to 8 p.m. We had 5 overdose deaths happen in a park in East Harlem during the hours that we were closed. And after being alerted to this by NYPD and the health department, we shifted our hours earlier to get people in. Our goal is to be 24/7. We are moving towards a 24/7 model.
That was my question. Is that a common model of 24-hour access in some of the other sites across the globe?
It depends. There are so many across the world, so some are 24/7, some aren't. We know and we see the impact of when we close. The MTA, for example, the transit department hates when we close because folks enter the subways and either sleep there or use there, etc. So there's a lot of buy-in to get us open 24/7.
Yeah. All right. So next we have a question from Dr. Collins, who is one of our emergency physicians, and he is also the EMS director for Cleveland. And he asks on behalf of all, well, first, he says, on behalf of all EMS medical directors, thank you. And I second that, and I think I speak for all of us. I mean, thank you so much. It's just incredible what you're doing. And then second, he asked, was there any difficulty obtaining liability insurance for program and employees?
Yeah, interesting question. So our liability insurance was covering us in our unsanctioned model. The details of how we got the insurance provider that we did, who wanted to cover us while operating consumption out of bathrooms, that is beyond my pay grade. But I can say we went to our insurance company and said, "Hey, we're gonna make this change. Would you still cover us?" And they said, "We don't see any difference between the bathrooms and the open floor plan, so it's fine."
Wow. Interesting. Okay, and then Daniel Lettenberger Klein, who is the CEO of one of our local treatment programs, Stella Maris, asks, "You may have hit on this, and I apologize if it's redundant, would like to learn more about how these programs are financially supported, and what's the runway on funding and structured?"
Yep, great question. So we are not able to use city or state funding at all, even though the city was lockstep with us in making sure they opened. They will not put any dollars towards these programs. So it is incredibly challenging from a fiscal perspective to run these programs. We are operating with private funding and foundation money. Our goal is to get opioid settlement money to cover this. The opioid settlement money, as you guys probably know, is coming through the health department. So advocating for our chunk from the city health department to go to this program is not only for us to keep being able to operate and keep our doors open, but also, again, to make a model for the country. If we can use the opioid settlement dollars for this, then hopefully other states and cities can do the same.
Incredible. Yeah. I just keep getting like more and more ideas when I hear you speak. And I think, Jean comments that this is simply one of the most mind-blowing presentations I have heard in recent memory. And I second that. I think probably that's the overall feeling of just about everyone on this presentation. Everyone needs to hear what you're saying. I mean, this is incredible.
I appreciate that. It's also a very normal reaction to harm reduction. When I first started working in harm reduction, I felt like my entire worldview flipped upside down. So I appreciate you all being along for the ride to flip your perspective upside down.
Anne also asked, how do you get information out about the program? Is it mostly word of mouth?
Mostly word of mouth. It's our most successful way of getting people in, because friends tell friends. The other way is we have really robust outreach and public safety teams that are going into the parks and public spaces where people are hanging out and using, working with community members that way to get the word out. And then we have a whole social media apparatus, but most of the folks we serve don't have phones, so they're not seeing that part.
All right, and I see Vince Caraffy has his hand raised. Vince is the former opioid task force director for the County Board of Health, and he now works with us at Metro Health at our Office of Opioid Safety. Vince,
thanks, Jonah. Please, Pia, thank you very much for sharing the information. You had mentioned several times as far as peer review journal articles pertaining to the research on this specific subject. I think it was a couple years ago, we were doing some work with some syringe exchange, and there was, I want to say his name was Keith Humphreys from Stanford. And he had put together some literature, and I think he put something out in 2019 that basically said that there wasn't enough research yet to say it works or say it doesn't work. So what are the things that you're looking at since 2019 or data metrics for us in a county where it's difficult for us even to get a syringe exchange van accepted in different areas, the counties where we see hotspots? So what is the new data that you're referring to, or peer-reviewed articles that you're referring to that we could use to say, okay, this is what works? I think that's extremely important.
Yeah, for sure. I'm surprised to hear that. I'm surprised and I'm not surprised. Let me say that. I'm surprised in that there is peer-reviewed data before 2019. Like I said, the first supervised consumption facility in the world opened in 1986. So these have been highly studied. That was in Switzerland. I'm pretty sure we have a list of peer-reviewed articles to access. Let me hunt that down. But I think more so what's often said is we don't have enough data here. we don't have enough data to know in the US, is this really going to work or not? And we're providing that data. And it's early days, but we're seeing the exact same trends as what the historical data shows. So I think
Thank
I just get your hands on the right pieces of information.
Thank you very much.
Yes.
So next, I don't see any more questions. Maybe I'm missing them, but I'm going to pick on our syringe exchange staff at Metro Health, because I know that they are really eager to replicate your model in any way they can. So I'm going to ask Stephanie and Becky and Roger, do you have any questions for Pia? You guys have been real quiet. And maybe they're not with the, no.
Hi, this is Becky.
Hi, Becky.
So I kind of help with the syringe and Project Narcan program in a mobile unit. Do you have a preference on a type of model at this point that seems to be more effective than another model, the different models that you provided?
I don't really have a preference, because my preference doesn't really matter. Like, it's about the preferences of the people using the site, right? So
right.
The preferences of the people using the medical model are for a more medicalized model, the booths, the privacy. And in the Heights, it's really, really more of a draw to our younger users to have another user or former user to rely on, to supervise them, and to have an open concept with tables where people can hang out and talk and we can play music. So it's very different vibes. I've also worked on the mobile setting. I think the mobile setting has a lot of challenges because you're working on such a confined space. So I wouldn't say that the 9 overdoses and the 2 heart attacks were easy on a mobile unit, but I mean, the impact of a mobile unit is really tremendous when you're up against a landscape of nothing, right? So I don't necessarily have a preference, but I do think that they should be tailored to the communities that you're serving.
And if I'm hearing you correctly, you're saying the outcomes are the same, essentially.
Yes.
Yeah. Okay.
I mean, the NIDA study will show that officially for the US, but there have been, there's already been research done about different models all over the world, and the outcomes are the same.
Thank you.
Amy is asking, have you had demand outstrip capacity in either of your facilities at this point? And are you getting lines or long wait times?
We do have wait times occasionally. This is happening kind of in 2 different ways. So either wait times for smokers, because of our high volume of smokers in East Harlem. We wish that the smoking room could fit double. In Washington Heights, we have an interesting like ebb and flow of the day. So sometimes we're slammed and sometimes we're empty. And that often corresponds to the hours where people are hustling. So there are times where people have to wait, but again, the way that we manage to not have time limits is by managing the flow of who's coming in and how long are they staying. So if somebody's sitting at a booth and not actually making progress with their use, they might be like sorting their things which they're not supposed to do. They might be just looking at themselves in the mirror or talking to someone. We're going to be like, hey, my guy, like this is for using drugs, focus. Or you got to get out because I have somebody waiting. So what do you want to do here? That's how we manage that. And so, yes, I think it would be great if we had additional capacity, but we are making very good use of the capacity that we have.
Good. And I see that Dr. Stream put a couple of those peer-reviewed articles in the chat. Thank you so much for that,
Yeah.
Dr. Stream.
Sorry for the obnoxiously large font. I couldn't figure out how to drop the font size down.
So great. So that's really helpful. And then, yeah, we would love to have any other resources that you have available for us. Well, I think we are now at time. I want to thank you again for coming and giving this presentation. I think Jean said it best. This was mind-blowing and just incredible information. I'm so grateful for your presentation. And I suspect that even though we recorded this and we're going to share it, I have a feeling that you may get a few more invitations from the Cleveland area, as this is really going to spark some discussion and conversations moving forward.
Thank you so much for hosting me. Please encourage folks to reach out if you can make a visit possible. We'd love to have you and show you the spaces.
I think you'll definitely have some takers on that. And so thank you again. I think we just have a few closing announcements and reminders for folks who are on the call. We have 2 upcoming CME courses. The APRN Call to Action Improving Access to MOUD and Other Evidence-Based Interventions is September 27th from 8:30 to 4:30. We're going to have an in-person and a virtual hosted event in partnership with Ursuline College. And we also will be hosting the 2022 OUD CME course. I think that's actually Cleveland Clinic and David Stream's course. That's November 5th. And the registration information can be found. There's a link in your agenda. Our next meeting is November 2nd, 2:30 to 4 p.m. And with that, Amy, do you have any other final closing remarks?
I do not. Thank you so much, Pia, as well from myself. I will, if anybody does have any peer-reviewed literature, we'll consolidate that and maybe create a document and send that out along with this meeting link. We may end up having some follow-up discussion at future meetings, so we may reserve some time in our upcoming meeting to have some follow-up discussions. Does that sound good, Joan?
That sounds great. Thank you
Okay.
again. Thank you so much. And enjoy the rest of your day. All right.
Thank you,
Thanks,
everyone.
everyone.
Bye, everyone.
Thank you.